for questions, clarifications, and ideas on how to take this forward. So feel free to ask questions. Questions?
Everything was 100% clear.
Yes.
You mentioned the use of some form of improved cooking stove, and I didn't see it reflected in your survey results. Because I would think that's a very important fact. And the position of the cooking instrument in the household, whereas it is important, the location, but also the position. Because a stove which is at an elevated level may produce less pollution than a stove which is at one level.
Sure. So your question is about, did the survey capture this information on improved cook stoves, and it assessed where people cooked, but not kind of the elevation of where people cooked. So I can kind of go back to one of my slides real quick, just so it's clear what I did. So we did look at the type of cook stove that people used. Sorry, I need to go back into the slide mode. Well, what you can't see, but I can see, is that, so we asked people about the type of stove that they used. And basically, did they use a stove that was vented? Did they use electricity? Did they use a liquid petroleum gas? Did they use a kerosene? So we asked people about the type of stove that they used, and then we asked people about the type of fuel that they used. You can combine that information to kind of qualitatively say, okay, this is an improved stove, and this is kind of a traditional stove that's unvented. Does that make sense? This study wasn't an intervention study saying, I'm going to, put some clean cook stoves in here. We relied on people's self-report of the types of stoves they used, whether it's vented, unvented. There may be some error in how that people report that. For instance, I did some household air sampling on a subset of the population. Somebody reported that they cooked with fire and that it was unvented. But when I went to the person's home, they cooked with fire and it was indeed indoors, but they had a chimney at the top of the structure that they were cooking in. But that didn't come out in the way they reported. So there's some error in that assessment. But that was the only instance in my kind of going out to people's homes where I saw kind of a discrepancy between what people, we could say about 10% maybe misreported on that. But what we see here is what I classified improved stove as electric stove, liquid petroleum gas stove, or traditional stove, but it has a vent. So what I mean by traditional stove is it uses charcoal or wood. And only 6% of the people cook with that. So it's almost impossible to assess that. Is there a difference? And it turns out there is no difference in the prevalence of these outcomes based on the type of stove because these numbers are so small. But this is also kind of a nice benefit of the study is you have this homogeneous exposure. That gives us the opportunity to look at these other factors. If you have a 94% of your poor population using traditional unvented stoves, using traditional cooking fuels, being able to do a cook stove intervention in that context has a lot of problems, because it's supply driven, partially demand driven. It's what's that? It's such a consistent practice of using these kind of what we might consider less efficient stoves that are unvented. It's such a common practice that to intervene is going to be an immense undertaking. So we're certainly not going to give these, people aren't going to magically start using using electricity or using gas These are very cost prohibitive for people. I complain every day about the electricity and the gas that I spend here in New York. But, and I'm not, living under $2 a day. So I think, one of the benefits of the study, again, just to reiterate, is it's a fairly homogeneous type of cook stove that people are using. So we can look at how these other factors tend to matter. But also from as intervention strategies, we have to think about where people are and what you can meaningfully do in a reasonable amount of time to protect public health. But it's a good point. So regarding the elevation, so I think the point is there, if you're cooking higher, that it's the pollutants can be better ventilated away from people's breathing spaces. Whereas if you're cooking lower, especially if you're a child, that polluted air is going to come into your breathing space much easier, and it's going to be not going to be entrained into the into the air as easily because the particulates can settle to the ground quicker. So that's a very important thing, or a very important point to make, is we didn't assess the level of cooking location, and that's, I think, something in future work I can put a better emphasis on.
Okay, yes, Elizabeth.
Thank you very much for that nice presentation. It's excellent, and this tackles a very important topic, especially in child health. I'm very, very critical, and I'm interested to know about in-house smoking, because much as the numbers were quite few, there was a significant impact across the board. And I know very well for a fact that high-income countries have a higher burden of cigarette smoking, tobacco use, and outdoor pollution. How would you compare? I know, I don't want to sound biased, but I know underdeveloped or developing countries will have a high burden of infectious diseases, and now the burden of air pollution and in-house pollution is increasing. But how would you compare the effects of outdoor pollution in the developing countries compared to the developed countries? And maybe in your future studies, would you really consider tobacco smoking, specifically second-hand and third-hand smoking, on the effect of respiratory disease?
That's a good question.
Before I used to think, when I traveled and I saw people walking with cigarette smoking and fumes everywhere, and with developed setting, many industries, and a lot of activities, I imagine there's a lot of pollution, and I want to cause me no. You understand? Of course, what is a lesser evil in this case, where someone is cooking in-house, a small room, no window, and they're inhaling all these fumes? I wouldn't want to feel that in sub-Saharan Africa, we're about to die. You understand? How would you, without any bias, how would you compare the issue of air pollution versus the effect on respiratory disease in high-income countries and developing countries, so that we don't feel like all of this law?
Okay, sure. So unbiased. Let me be perfectly clear. There's no way I could be 100% unbiased because I have my own worldview and perspective, and have my own context. So with that being said, there are things I can say empirically based on data that exists. We do know that outdoor air pollution levels are higher in the lower income countries. So we know that. So the premise that outdoor air pollution is worse in these higher income countries may not be accurate. So we have data to suggest that it's probably worse in the lower income developing countries. So starting from that point, and then also the issue of indoor smoking. So indoor smoking prevalence in places like the U.S. and Europe has gone down dramatically over the last few decades because there's been all these smoking cessation interventions. I saw a prevalence here of 8% in my study. So 8% of the people, almost 10%, were smoking indoors. So there was a national survey done in Uganda, found probably around 15%, 12 to 15%, depending on the socioeconomic status of the home. So my study found a slightly lower prevalence of smoking. So I think I can be fair in saying prevalence is probably a little bit higher than what I found, and that's probably because I'm dealing with a low-income population that can't really buy cigarettes so often. So from that, so there are some data to suggest that prevalence is slightly higher than what I found. And the effect estimates that I found for smoking were the highest of all the household air pollution factors that I considered. So clearly smoking indoors is very important. Whether or not I want to single it out as the one point of intervention, I don't think I would actually go that far, because my data would suggest that there's a myriad of other factors that we have to consider. We can't just remove cigarettes from people. First of all, it's behavioral intervention, and that's, good luck with that. And then you have 80% of the people cooking with charcoal in Kampala. So I don't want to say that all hope is lost. That wasn't the point of what I was trying to make. Is that understanding that context is important, and facing it and saying, okay, if basically everybody is using charcoal, and we're not going to realistically change that in the next 5 years, what are the other underlying issues that could be addressed, whether it's housing issues, whether it's behavioral issues, which is again a tough nut to crack. What are the other underlying factors that could be addressed in the interim? I think that's the kind of larger point, I think. And I don't want to point to one thing and say that's the whole point of was, it's a myriad of factors. So that's kind of what I would say.
Thank you, Eric, for this impressive bit of work. My one question is, I imagine there are people who don't use one type of fuel. So you find you use charcoal, you've stayed in Uganda for some time, so if I'm cooking matoke, I'll use charcoal. Then I use gas, then there's electricity. So there's kind of people who just have this kind of mixture, not like purely one type. Did you come up with a variable to try to look at that? I think it would have been interesting to look at those who do the mixture of the fuel and then the effect of the outcome.
So that's a good point to make. So there's something called fuel stacking, where people use multiple fuel types and for different purposes or similar related purposes. So somebody might be cooking with charcoal because, cooking your matoke and the banana leaves with the charcoal and the sagiri is like way more awesome than on an electric stove. And I agree. My wife is Ugandan, that's the way she cooks the matoke, and it's much better than what she does on an electric stove. It's a question that I had in there originally, but there were some issues in my pilot testing where I noticed some issues with the way the community health workers were reporting the data. It wasn't clear if they were being consistent. And also, I just decided to go with what the World Health Organization does, the way they frame it. They say, what do you typically or what do you usually use for cooking? Which leaves a lot to be desired, because there's this issue of people using multiple fuels. So I think in the future, if I can come up with a question that is less prone to data entry errors, because people were the community health workers were giving responses that I wasn't comfortable with, and I didn't want to have a data set with variable that was not going to be helpful. So there was some pilot testing that made me shy away from it, but I'm sure there's people, I don't need to reinvent the wheel, I'm sure people have addressed this issue. So I think that's a good thing to do in the future, is find out this variable fuel use for cooking and see how that matters.
Yes,
thank you so much for that very interesting discussion. The data was quite interesting, and it's not really very surprising. If you've been to those areas where the survey was compared to some country places like Arua, Maracha, where really the air is clean, and they have one hut where all the cooking is done, and then you have basically different huts where the people really stay. So you have to realize they don't have both ambient and household air population. When it coming back to this particular study, was there a particular age group which was most affected? Because you want to imagine that during the age where a child is very dependent on the mother, they're really around them all the time. Cooking, and when they start school, they're out of the house and playing, and then they come back at night when the cooking is done.
Yeah.
So you actually realize even that the window effect may not actually affect their asthma attacks and things like that, but you know,
Yeah, so that is a really good point, and I'm glad you brought it up. So the graph on the right is kind of, it touches on what you're talking about, right? You know, the younger you are, the more often you are indoors during cooking times. You see here, more than about 80% of the children that were indoors during cooking activities were under 5 years of age, right? It's because like they're just kind of around the mother more often. So I did try to look at kind of like effect modification by age. There wasn't anything there, but there's no way I can be declarative in what I'm saying because the vast majority of my study population were children under 5. That's because that's the population that comes into these facilities. So it was hard for me, to be honest, to be able to assess that empirically. But I think it's a really good point because not only are younger children more susceptible in terms of exposure, but they have less developed immune systems. Their breathing rates are higher than older kids. Their lungs are more susceptible to respiratory harm. So I think if in future studies where I plan on kind of looking at folks that are not just these health KCCA folks, we're going to get a broader cross-section and maybe do more purposeful sampling of age groups. I could potentially address that. But I think it's a really good point to make. I'm amazed here in Uganda. So let me just say one thing. In the U.S., do you think boarding school is very common?
No.
Not at all. I don't even know anybody in my whole life that ever went to boarding school. But here, I mean, it's incredibly common. I know a ton of people whose child goes to boarding school. So there might be all these cooking practices going on inside the home. But if the child is away in boarding school for 95% of the year, what meaning does that have? So I did have a question in the survey about, is the child usually home? Is the child usually home at night? And I haven't had a chance to look at that question, but it might be worth. I don't even know if it remained in the survey. There may have been issues with the pilot testing. I have to go back and look. But it's again, it's a really good point that you're making. Deserves more attention.
I'd like to know if this study had something about the level of awareness and study population, like to get to know these people and know the effects of the poor practices, and if this influenced in a way how they will practice, how they will cook it, in the physical outside, or if not, if the level of education of the parent influenced the kind of practices is studying the
So, very good question. So, for those that may not have heard, it's like, what is people's awareness about these household air pollution factors that I considered in my study? And then the other part is, well, does people's individual education, does that matter? So, regarding the first part, I didn't have a question that explicitly addressed that. There's a question about outdoor air pollution and their perceptions. So people's perceptions of outdoor air pollution was very negative. I mean, about half of the population said they were a quarter of the population said that they were very concerned about traffic pollution and trash pollution. And then another 25% said that they were somewhat concerned, and then the balance said they were not really concerned. So I think that there is some awareness of the outdoor air pollution issue, but I think there's a big drop-off, even though I didn't have a question about it, I think there's a big drop off with this household air pollution issue because I had a lot of back and forth with my community health workers. They would often say that, the parents would often ask, is that a bad thing? After they answer a question, they're like, is that bad? Should I be doing something different? So I think that there is poor awareness. On a subset of homes, I did do some household air pollution sampling, about 10 homes or 11 homes that I sampled. Some people were interested and some were somewhat disinterested. Those disinterested, I wonder why they wanted me to come in and sample, but that's another issue. But the ones that were interested, didn't really know. I had dialogue with these folks, some of them, because community health workers were there and could communicate some things that I couldn't. But there is a lack of awareness as far as I can tell. And I think it would be interesting for people doing some community-based work to find out people's perceptions of indoor air pollution, number one, what factors go into bad air pollution, what factors go into good air quality. I think that would be fascinating work for people because, if people aren't aware, then you certainly, because behavioral change theory tells us people need to be aware and they need to be able to do it. I think that's a good area of research. I hope to do more work in the future, and maybe I can work with folks like your organization that do community-based work. So, regarding the education question, I think, unfortunately, I don't have this awareness question. Maybe with the outdoor air pollution, I can address it. But another issue is I asked about the household education of highest attainment for the household. So rather than asking that specific person that I'm interviewing, so that's going to be difficult to address in my data. So that's my response.
More questions? Clarifications? I can now take my turn. I was kind of curious why you considered cough for 2 weeks or more. I have a feeling you could have left out many of the children, that the pediatricians in the room will testify that most of the children may come with short, periods of cough. Parents tend to, especially the under 5s, to try and come quickly. So what guided your cutoff of 2 weeks?
So that's a good question. It's good, this is a situation where it's good to have some context about the original idea behind my study was to look at tuberculosis. I rather naively thought that I could address this question of tuberculosis, but the numbers just weren't there to look at. Before the study started, Luke and I realized there's just not enough, fortunately, there's not enough kids that have tuberculosis to really address the relationship between air pollution and tuberculosis in the amount of time I had to do my study.
Or at least be diagnosed with.
At least be diagnosed with. You can kind of get some suspect TBs. In the algorithm for TB, it's like, they ask if you have a cough for at least 2 weeks. Okay. With my original study design, that's what we were going with, to capture the folks that are being screened for TB. But that being said, if a child has cough for more than 2 weeks, and there's no clear explanation behind it, we might want to know what could be the risk factors behind that. I think my study, I didn't have a slide on limitations, which is an oversight on my part, but things like acute lower respiratory infection, my study is maybe not well positioned to address that question because of what you bring up. There's kids that might be sick, having a cough for like 3 or 5 days or something like that. That's an important population to capture. But also, the cases of pneumonia that are most deadly are those ones that have this like prolonged, persistent cough. So maybe my study is kind of capturing those more severe cases. But I think certainly the limitation is my study is like missing those folks that have these kind of short spurts of acute cough. So when you look at the definition of there's something called acute prolonged cough, which is cough from 2 weeks or more. So my study kind of addresses that acute prolonged cough, but not this kind of quick acute cough that could be pretty meaningful.
And just a follow-up on that, because in one of the studies that I did looking at trying to find out the proportion of children who have asthma, majority of them actually came with short periods of cough. So you might find that maybe the prevalence of asthma could have been higher had you considered just probably any cough. And it also addresses the fact that they can come with short periods of cough but kind of recurrent, and therefore it eventually fits in the diagnosis of asthma. Then the other question which I have is on ethical principles, like the children where you found they had asthma, what did you do about them? Did you diagnose post-op, or you had an opportunity to diagnose and do something about it?
Yeah, so very good question. So this ethical question, you just found a child that could potentially have asthma. Did you do anything about it? And unfortunately, this was a post-hoc analysis. I had these community health workers, they weren't in a position to quickly ascertain what are these responses meaningful for asthma. So that's kind of unfortunate, because based on what I am able to assess with the way I collected the data, there's a lot of children going undiagnosed with asthma, and I think there was a study with Lago that made that point very clear. And my study might support that, even though I don't have biologic measurements of lung function and that sort of thing. There's several instances where I have. We'll go back to the algorithm that we used. So we use in the past 12 months for any lifetime episode of asthma. There's a question on dry cough at night in the past 12 months. I had several instances where children fell into almost all of these categories, or more than 2 categories, and that's a good sign of asthma in a child, I would think. I'm not a pulmonologist, but I was an advisor. But I only found like a handful of cases. I think it was 8 cases of asthma where because I have access to the patient records as well, so that was concerning to me, where I had about prevalence of 20% asthma based on this algorithm, and less than 1% have a diagnosis of asthma. And only again, like 20 parents, I think, reported that their child was diagnosed with asthma before. So, that seems to be a problem.
Okay, thank you. Let's join hands to give our